everybody to the Tropical Australian Academic Health Centre webinar series. I begin today by acknowledging the traditional custodians on the land on which we all gather. For us here in Townsville, it's the Wulgurukaba people and Bindals people, and I acknowledge and pay respects to the elders past, present and emerging. So my name's Rae Thomas and I am the Research Education Lead for TAAHC. And today I'm performing two roles, which is a bit unusual. I'm both the facilitator and I'm going to give you a very small talk right at the start because the two stars of today are Sally West and Ben Glenwright. So I'm not going to take up much of your time. But before we get started, a lot of you here might not know much about TAAHC. So I'm going to give you a brief introduction about who we are and what we do. And my assumption is that my screen says you can see my screen, so I'm assuming that you can. So the Tropical Academic Health System, also known as TAAHC, was born out of a long history of collaboration between agencies in Northern Queensland. We are currently a collaboration of 5 hospital and health services districts in Queensland, in North Queensland. They're Mackay, Northwest, Torres and Cape, Townsville, Cairns and Hinterland. We also are partnering with the Northern Queensland Primary Health Network and the Queensland Aboriginal and Islander Health Council and James Cook University. We have research themes that we like to stick to, and today's research topic does fit quite well into those themes. So we talk about service delivery and regional, remote and Aboriginal and Torres Strait Islander populations. We also talk about innovative health workforce models. We talk about non-communicable diseases and we research into that space, particularly those of high regional prevalence and infectious diseases. Right down the bottom of this slide is a really big www.taahc.org.au. I really encourage you, if you don't know much about us, to go and explore our website. We have event calendars, things that we're doing, webinar series, all the recordings will be put up there as well. So please do have a poke around and a bit of explore. So again, just a bit of housekeeping. If it's possible, thank you all. I feel like we've all got our mics muted and cameras off, particularly while the presentations are happening. But by all means, at the end of the presentations, when there's Q&A, please put your cameras back on, and by all means, unmute yourselves if you have particular questions. So the Q&A will happen after all of the presentations have finished. Okay. Please put any questions you might have in the chat at any time and raise your hand in the panel discussions if you'd like to ask your question by yourself. Otherwise, Bonnie is going to help monitor the chat for me so I don't have to do that as well, because I'm not very good at doing multiple things at the same time. So today's speakers, our overall theme is translating research into practice to improve health outcomes. So as I said, I'm going to talk first. I'm very, very briefly just telling you what research translation is and why it matters. Ben's going to talk about his translation journey from QI to PhD. And Sally's going to talk about implementing nasal high flow for children in Torres and Cape. So me first. What is it? What is research translation and why does it matter? So first of all, research translation is a role known by many, many, many names. It's known as knowledge translation, knowledge transfer, research utilization, research implementation, knowledge uptake, knowledge mobilization, knowledge exchange, and a whole lot more besides those. But what you'll find, and what I've done with the word cloud, all of those research and knowledge are actually the core, most important words that you need to think about when you're talking about research. Because we should only conduct research translation activities when the practices that we're wanting to translate have strong evidence base. That means we know that they work because they have been researched by either ourselves or others. But research translation isn't about just making sure all of our research gets into practice. It's about making sure the best research gets into practice. So what is research translation? So the Canadian Institute of Health Research defines research translation as a dynamic and iterative process that includes synthesis and dissemination, exchange, and the ethically sound application of knowledge to improve health, provide more effective health services and products, and strengthen the health system. And all of that occurs within a complex system of interactions between researchers and knowledge users. And it depends really on the nature of the research findings and the needs of the knowledge users. And you'll see that when Ben and Sally talk about what they've been trying to do in their respective clinical fields. It really is about bringing the context of the particular situation into the practice that you want to embed. Why is it important? In 2020, Jeffrey Braithwaite and his colleagues identified that for the past 3 decades, the health system has operated on a principle of something like 60, 30, 10. That means 60% of healthcare that we deliver as clinicians is evidence-based or consensus-based. 30% of the healthcare that we deliver is low value, and 10% of the healthcare that we deliver is harmful. So research translation's goal is to improve the 60%, make that higher, and reduce the 30% and reduce the 10%. And 3 decades is a very long time for us to be operating under the principles of 60, 30, 10. But let me just read you this for a minute. It says, it's remarkable and lamentable fact that many years often elapse before an important and scientifically established discovery in either the theory or practice of medicine becomes essentially constituent of diagnosis and treatment in the hands of the practicing physician. And what I really liked about that quote is that it was written in 1896 in a JAMA. And it hasn't really changed, and we need to get better at it. On average, it takes around 17 years for an identified evidence practice gap to move into clinical space. That means that when we have identified there is a better and more effective way of doing something without research translation activities, it takes about 17 years to put that into practice. If we use research translation activity, on average, it takes about 3. So we'd much prefer to use research translation activities than not. Otherwise, we go right back to 1896. So just to let you know, research translation is about changing how people behave and by implementing evidence-based new information. So that requires behaviour change. And I want to present 2 slides to you to show you that there are really helpful structured processes and theories to help you guide how you do research translation. So 2 of the ones that I have on the slide are the behaviour change wheel from Susan Mickey and the theoretical domains framework. And these fit quite nicely together. And I think you'll see that the people that Ben and Sally that are talking about today have used some of these frameworks to guide their implementation. So the behaviour change wheel talks about looking for right at the core of the circle is behaviour. When we want to change behaviour, we have to figure out about people's capability. Are they able to change their behaviour? Is there an opportunity for them to change their behaviour? And are they motivated to change their behaviour? And then across the other side to the theoretical domains framework, within those 3 concepts, you're able to figure out where are the barriers and where are the facilitators that help or hinder behaviour change for people. All of that requires lots more information, and I'm not going to do that today. But listen to Ben and Sally and how they did that. And then how you go about doing research translation. 2 popular ways, 2 popular process ideas for research translation are the knowledge to action cycle and the consolidated framework for implementation research. Again, all of these are really well established, published, popular frameworks and theories, and you can have a look at those. So right now, I'm going to hand it over to Ben. And while I'm going to stop screen sharing and Ben can start his screen share. And while I'm doing that, I'm going to introduce Ben. So Ben is a senior physiotherapist in acute orthopedics at Cairns Hospital. He's got 14 years experience practicing as a physiotherapist, mostly in acute hospital ward-based work. His is a budding early career clinician researcher career, having commenced his MPhil in 2020 and recently upgraded to a PhD at the beginning of 2023. Nice work, Ben. All right, over to you, Ben. Oh, Ben, you're on mute, mate.
There we go. Thank you for the introduction there, Rae. Apologies, I have a 3-month-old in the background, sorry. Oh, come on, she doesn't want to play. Great, so what I wanted to talk about is my trip journey, quality improvement to a PhD, but obviously just wanted to sort of share how I got to that and obviously talk you through a bit of the implementation science frameworks that came across through my works. So understand a clinician. So there's more than one way, but a journey to that translating that research into practice. Understand one of the many pathways into research and the importance of journey, not always just the destination in trip and research. And I think that's something I'm still learning as I go, which will continue to develop across my journey. So I've come to know translation research into practice as TRIP. As Rae pointed out, what got me fascinated in it is this 17 years to move evidence into practice, because we're always wanting to, put the best evidence forward and give our patients, clients, the best care. So I just want to use an example I found, which we can all sort of relate to recently with how well the COVID vaccinations were able to be conceptualized and developed and implemented. But the National Institute of Health strategic plan established that moving a new drug or medical device from conception to market takes 14 years and costs $2 billion. So it includes 6.5 years of laboratory-based drug discovery and preclinical testing, 6 years of clinical trials of promising drug candidates, and then a year and a half, for example, in the US for the FDA approvals that are brought to market. So it's very interesting to read something like that and see what, when we all steer in the one direction with the COVID vaccination, how things can evolve. And again, there are the gaps that impact that delay. So the systemic barriers such as lack of integration between the health and the research, that is what you're trying to bridge. The diazomic metrics, the organizational and professional silos, pervasive competition, lack of collaboration, and failure to engage relevant stakeholders. So my journey started back in 2018 when I actually just got an email and through my personal email through the network that I'm involved in. It's the Orthopedic Physiotherapy Network of Queensland, and came across this article, and it really just hit me and sort of in the sense that it was very much what we should be doing, but we weren't. So it was looking at the supervision after someone has a total hip, so my orthopedic background, and looking at an RCT that just said not everyone has to do it, but hence we currently refer everyone. So just taking a little step to the side and just want to give you an overview of my learning journey. So I went to an OSHI workshop on translating research into practice in June 2019. Apologies. I snuck a slide in, that's on a timer. And that was something that really opened my eyes to translating research. And it was more so from a point of just a quality improvement. I didn't even have an inkling of looking at doing any higher research. I recall on the day, or it was a 3-day workshop, but on one of the days, someone talking about their PhD, and I was like, oh, wow, that is intense. I don't know if I could do that. Come to November 2019 and actually started an ERAS project. So ERAS stands for Enhanced Recovery After Surgery. And I coordinate that with a group of key stakeholders. And that essentially I'll go through in a moment. That then moved to, okay, I want to know a bit more about this translating research. And for those allied health professionals on today, there's what we call RTRIP, Implementation Support Sessions through Queensland Health Initiative. And I'll share some resources at the end, but non-allied health practitioners can obviously go on the website and look at some really good resources about getting a better understanding of TRIP. And then out of those TRIP sessions, I sort of got prompted, hey, this might be more of a research question when it came back to my rehab post-TAAHC, and I went, okay. And I commenced a master's, which then has evolved into a PhD as of this year. I'll just, this was an overview of a presentation I did. It's just the main slide, but it was looking at taking a trip in orthopedics, enhanced recovery after surgery for patients in a regional experience. That was my first sort of, again, excuse the pun, but trip into translating research into practice. And it was very rewarding. I learned a lot. There's a lot of things I did that I would have done differently. But on my next slide, what it talks about is, for me, it was going from the PDSA cycle on the left, which we're all quite familiar with, and then looking at that knowledge translation. So that's on the right, but it's configured to an RTRIP process. So it looks at identifying the clinical problem. So for me in the ERAS, it was, we weren't doing the best care principles as per the consensus from international clinical guidelines. We then needed to support that change, plan for the change. We looked to implement and evaluate that and look at sustainability. So that was sort of where I started my TRIP journey, looking at QI, looking at quality improvement or quality assurance, looking at sort of that knowledge translation framework. And with that, we had, some strategies that came out of that. We're looking at multidisciplinary working groups, needs assessment, clinical leads, and establishing that strategic and implementation plan. What I learned from that journey in the early stages was plan. Excited when you're able to deliver that service improvement. Project can be small or big as you make it. Reach for the skies. Big project, ensure there's a clear and concise question being asked. Small change in service delivery can deliver significant changes to the consumers, as we know. I then evolved to my thesis, which is looking at the co-design and implementation of self-directed rehab pathway of care for patients following total hip in the Australian context, and in the sense of a stratified care approach. So just real briefly, some background there was total hips, gold standard for people with osteoarthritic hips. We do about 40,000 in 2019, and that's meant to double to 2,208 by 2030 from 2019. So massive burden on rehab. So what we're currently doing isn't sustainable. Traditionally, it's been supervised, about 55% referral rate in a national survey in 2018. The 4 HHSs in Northern Australia that make up Forest, Cape, Cairns, Mackay and Townsville all do a blanket referral currently as standard practice. So I don't know if people know, but modern clinical practice guidelines have been sort of in place since 1992. However, 30 to 40% of all medical patients, as an example, may receive treatment not based on guidelines. So there was new clinical practice guidelines that I needed to look at implementing, but I needed to do it in an effective and successful manner. And that was through the joint replacement, primary hip, knee, shoulder, NICE guidelines. And just on the side there, looking at what are some facilitators and barriers to clinical practice guidelines that were found in the literature. And they're all things that we know quite well. Then going on to the implementation science theoretical frameworks that I'm now incorporating. So looking at that trip, and some of them have been touched on by Rae, but for example, the Consolidated Framework of Implementation Research, CIFA, systematically looks at facilitated barriers across your micro, mesio, and macro levels. And that underpinned a recently published systematic review, whereas then I moved to a framework that looks at theoretical domain framework, and that is looking at the individual barriers and facilitators to change, and that will guide a participatory co-design workshops, and then looking at a re-aim framework that will guide the design and evaluation of a pilot program. So just wanting to highlight, there's multiple frameworks, there's hundreds, but it's looking at what is needed to look at getting success for your translation of that research to clinical practice. To sort of finish off, what I wanted to just highlight is, this is a really good link, which we can share later, but translating research into clinical practice is available on the internet. It doesn't have to be via QEPS, the intranet. And what it has is it's translating research into practice. And what I've highlighted there with the arrow is this training and education. There's a lot about foundation training, identifying a clinical problem, evidence to support that change, and then goes through the processes of that knowledge to translation. So it's very much a really good starting point for resources that I would encourage individuals to look at, where to look into translating research in practice. And there's preferences I had, but that will be all for me for now, and I'll hand over back to Rae. Thank you.
Thanks, Ben. I really like you juggling parenting in there.
Yeah, I apologise.
No, well done, you. I think that's multitasking at its best. Well done. Congratulations. Look, I'd like to introduce, if it's okay with people, please, I'd like to save some questions until the end so we can have a proper panel discussion and tease apart what we've been talking about today. There's some really great resources that Ben has talked about, and he can perhaps speak to them a little bit more. I'd like to now introduce Sally. Sally is a registered nurse. She's worked clinically in rural and remote communities for the past 10 years with a particular interest in reducing health disparities between remote populations versus urban populations. Her current research is evaluating the implementation of nasal high flow therapy in remote context and translating the evidence for this into therapy in a remote context. Over to you, Sally.
Hi, thanks everyone for having me today. Yeah, as Rae says, I'm a nurse and weeper. I'm very much clinical based. I happen to be a PhD student also, and that's with James Cook University. And I just wanted to, I am based in Weipa, which has been really useful for my research. I wanted to preface this by saying I'm in no means an implementation science expert. I'm learning as we go, but I really wanted to show you how we've used it and how I found it useful in my research project. So my research project is around using nasal high flow in providing equity of access to nasal high flow therapy in 3 remote sites. So by remote, I mean geographically remote. And the 3 sites are Thursday Island, Weipa and Cooktown. And we were really lucky that when I started looking at this research a few years ago, that we could see that there was already existing quite prominent nasal high flow therapy for kids research already happening, and that was with what is called the PAAHC group. So that's pediatric acute respiratory intervention studies. So they were looking at it from like a really tertiary, real efficacy type study, and so we were able to collaborate together. And they're also based in Brisbane, so they're some of the best in the world at looking at this topic. And we're really lucky it was quite Queensland based, and they've collaborated with me, and so that's why my project is called PAAHC Remote now. So first, I would like to acknowledge the traditional owners and custodians of the land around Australia on which this webinar is taking place, especially for here with me and Weipa, the Allnuth people. I would like to acknowledge the Aboriginal and Torres Strait Islander people and their connection to land, sea and community, and I pay my respects to elders past, present and emerging. So today we're talking about what was the problem, how did this come to be, why did I think that was important, and how I use implementation science within this project. So what we know about nasal high flow is that it's a relatively non-invasive breathing device. I'm just going to move this over so it's not distracting. So it's a relatively easy to use breathing device that can be used for children with respiratory disease. It's available for all ages, but my research is focused on kids. And it basically, you plug it into the wall, it gives you nasal prongs, just like this little one here, and it provides a higher flow that can be humidified. So there's a bag of water attached, and then you can titrate. So it provides a higher flow going through the nostrils, and then it also you can titrate the oxygen amount. So it has been used for quite a while now. It hasn't. The research initially, when I started looking at nasal high flow therapy, say 10 years ago, when I first moved to Weipa, it wasn't the research wasn't around or published enough to say who was good to have it, but we knew it was available for kids with respiratory disease, and I knew that because I've been nursing for say 20 plus years, I had been previously working in a kids ward and emergency units where we were using it. We're starting to use it a bit more. And then 10 years ago, when I went to the remote setting, I realized it wasn't as equitably accessible, but I knew that it could provide a stopgap in between when kids come in with respiratory disease, we know that you can have standard oxygen therapy, and in the remote site, you could only gain access to nasal high flow, to standard oxygen therapy. And then in the absence of there being nasal high flow therapy available, it was really just retrieve, or if you don't have enough time, intubate that patient and retrieve. So if the patients were becoming more unwell, you didn't really have many options in the remote site of what treatment you could provide available for that patient. And so this is really significant for us in the remote site, because we know that in say Thursday Island, Weipa and Cooktown, we know that we have a more densely populated Aboriginal and Torres Strait Islander population, and we know that Aboriginal and Torres Strait Islander people, their children experience a greater burden of respiratory disease than non-Indigenous populations. So this was becoming quite an anxiety-provoking scenario of the child coming into our hospitals, and we knew that these patients needed to get treatment for the respiratory disease, and in this case, let's say like bronchiolitis for this child, and we would either see that patient and give them the standard oxygen therapy and fly them out immediately. But I could see that some sites were starting to use nasal high flow therapy, and they were holding on to their patients a little bit more. And we could see that there was a discrepancy of nasal high flow therapy's use. And so we could see that, if some sites used it and didn't do as many retrievals, and so they weren't disrupting the family life, and patients were still getting admitted to hospital, yes, but gaining access to a treatment that was actually finding some benefit. And they weren't getting retrieved as much, but we could see that some sites were not putting it on until the very last minute and retrieving every single one of those patients. We could see that there was an opportunity there to look at how we could increase our capacity and our resilience for patients when they present to the remote site. Because you've got to think about it, if you're retrieving every single patient that say needs nasal high flow or becomes a little bit more acutely unwell, you're reducing that capacity or that knowledge base or the exposure of managing those patients. So in essence, you're de-skilling on looking after that child, and you're also de-skilling on how to use nasal high flow, and you're also finding yourself in a bit of a sticky problem if you're entirely relying on retrievals to manage those children with respiratory disease. If they need a little bit more than standard oxygen therapy, then you are relying on a plane or a helicopter or whatever the retrieval base is into the 3 sites. So in Thursday Island, it could be A helicopter and a plane. Weeper, it's a plane every time to be retrieved. In Cooktown, it's a helicopter. So you've got to take on all the problems that you're then relying on that you're taking on when you're relying on that retrieval base. So if there's a cyclone, you can't get your retrieval. If it could be busyness in the Cape and Torres, it could just any scenario. So when you're waiting for retrieval, it could, most of the time it's a few hours, let's hope, but sometimes it could be a few hours to days. And what are you going to do with that patient in the meantime? So we knew that we needed to create a little bit more resilience in our remote sites. So we thought, okay, so let's look at, well, why can't we just have nasal high flow? And you've got to think about it. This was, my project started 3 or 4 years ago, but we were talking about it for years before that. And I started asking around going, why can't we just use nasal high flow therapy? And I got some really actually quite valid responses from clinicians on the ground. And there was lots of anxieties around you looking after the sick child with respiratory disease in remote sites, because it's not about just putting in a device and a guideline and saying, here you go, this is, take it away, you can use this high flow machine on your sick patients, there you go. It was actually the fact that you can have nasal high flow therapy to manage these patients, but you actually still need to be quite good at looking after the sick child and be able to recognize that deterioration. So we knew that there was a lot more that went into how clinicians make decisions and how they really feel about implementing a new device like nasal high flow therapy. So some clinicians sort of said phrases like, we have sick patients that present and we retrieve them. All of a sudden, if we have nasal high flow therapy on site, will the tertiary sites, so in our sites, they get retrieved to Cairns and Townsville. So will Cairns and Townsville PEDS and ICU turn around and say, you've got the treatment that you need on site. We don't need to see your patient. You don't need to retrieve that patient. Or, how could we ever possibly resource the use of nasal high flow therapy? What does it mean if you put a patient on high flow therapy? Does it mean that every patient needs to be retrieved, or do they not get retrieved anymore? These are already remote specific cares that we're providing. So we have a staff, what would the staff ratio be if we were to use nasal high flow therapy? And what happens if we can't meet that? What will we do? Because, you've got to consider these remote sites have a huge turnover of nursing and what the training would be and so forth. So we asked around and we phoned friends, and we phoned a lot of friends, and we needed lots of help from research teams like the Paris team, like listed, grant organisations. And so we were really grateful to have the assistance from the Children's Hospital Foundation, the Emergency Medicine Foundation, of course, TAAHC, and every organisation that we got a grant from, we got more collaborations and more assistance. So we've been really grateful to have that. And also we needed help from Cairns, Townsville, Retrievals, and of course, Torres and Cape. We knew that we needed to go through an approval process, but we had to do, it took quite a while, but I'm not going to go into that too much now, just to say that I had a short learning course, but that sort of gets extended the more you go through these processes about how to, I soon found out I needed to get HREC approvals, and then public health approvals, governance approvals, and then COVID happened. So we then had to amend those approvals, and then we were able to launch our research. So I don't want to go into this too much because Rae's already discussed this a bit, but the 3 aims of implementation science that I will refer to later on is about, the aim number 1 is to develop effective strategies for implementing that evidence base. So in our case, the evidence base is nasal high flow therapy, and then improving that in order to improve health related processes and outcomes. And the second aim is to produce that generalizability by understanding the processes. So what is it going to take to get the nurse or clinician or the doctor on the ground that is going to use that evidence base? It needs to get into the hands of them, otherwise it hasn't made it. And then the third one is to develop, test and refine those theories using implementation science frameworks. I think the number one thing that I would be really proud if everyone walked away knowing from my presentation is that you really need to understand the context. And so in my case, we asked the health service, we did lots of community engagement. We asked what the community wanted, if this was even something that was a concern. Were people happy that their patients were just flying out all the time? Or, would they be worried if we started bringing in nasal high flow therapy? And we needed to ask researchers to see if this project was even feasible. So I'm referring back to the framework that Rae briefly put up before, the knowledge to action framework. And I'm just going to show you how we kind of made decisions and how the flow of my research project has been going. So our knowledge base, I'm just going to put a little pointer on. So our knowledge base is here. So we've thinking, I'm going to put in nasal high flow therapy in these 3 remote sites. We then need to figure out if this has been done before. What does the literature show? Do we even need to do this, or are we reinventing the wheel and someone else has done this before, or do we need to stand down? So in our case, we realized no one's published on how to implement nasal high flow therapy in remote sites. We had to do what I was just describing about consultating and figuring out what are these 3 sites for. And I figured out soon that Thursday Island, Weipa and Cooktown, exceptionally different. While they're also Torres and Cape, they're, different communities, so have different things that work. And then we needed to assess the barriers, facilitators, and we needed to continue that consultation process. But we decided to implement, and probably the biggest phase in our research was using an expert panel to develop a locally derived Queensland Health guideline. So with that, this was so that we had the experts who were the best people on the ground that know the context and know what will and won't work, and best poised to come forward and make decisions around how they think high flow would work in these 3 remote sites. So we had doctors and nurses from each site, we had nasal high flow experts, we had pediatrics in Cairns, we had ICU in Townsville, we had retrievals, and we got everyone together and we got them to adapt an already existing nasal high flow guideline that existed in like tertiary sites. And so we weren't asking them to change things in the guideline that wouldn't change over context. Like, it doesn't make a difference if you're, giving a flow, what flow you use across Weipa, say Cairns, that you're going to use the same guideline for flow rate, say. So they were going to look at really remote specific factors that really make an impact on how you would use high flow in the remote site compared to, say, tertiary derived stuff. So for instance, I would say probably the biggest differences that we figured out in that guideline was providing a flow of the disposition of a patient that went on to nasal high flow therapy, and consultation with tertiary sites and across the local sites were a big factor in that as well. So that sort of talks about, say you put your patient, you've decided you're going to go ahead and use high flow. That's great. You put your patient on the high flow. At what point do you need to locally consult and then consult with the tertiary site? Does it have to be straight away? Can you reassess in a couple of hours and make sure that the treatment's working and then reassess? And does that mean that they have to then go to Cairns or Townsville, or can they stay in the remote site? And there was a decision-making flowchart that really cleaned out those questions, and that was probably the biggest change in this guideline. There were lots of other little mitigating things, like, it created an automatic approval process to send out pathology and lots of like little details, but that was the guideline in essence. So they published this guideline, and then the health service informed us, the research team, on what implementations would best happen with what's the strengths and limitations on what implementations can we do. And so we used that literature review, and in our case we did an integrative review, and we mapped them onto a combi wheel, and I'll explain that in a tick, and we could see where the gaps were, that we could go and identify what is missing in what is already being done to what we could do in our implementation. And then, of course, we're in the process now where we're evaluating these outcomes. So we're, doing interviews, compiling a document analysis, and conducting a medical file audit. And so from then, we'll have to look at that knowledge and then reassess our implementation strategies in the future. So this is a wheel that Rae just showed before. So this is our the combi wheel. It's the theoretical framework that we're using to guide the research analysis. The concept of this wheel is that there is an interplay between the three main domains, and that's capability, opportunity, and motivation. And these domains represent what goes into behavior change. And then by influencing the three domains, you can influence behavior change. So from our literature, our integrative review, which is our literature review, we could see that there's already lots of implementations going on that exists already in the opportunity category. And we could see that the capability has the next most, and then hardly anything in the motivation category, which kind of makes sense when you think about it from health service delivery. We sort of talk about, like, when we're implementing something new, we sort of provide the resource and say, this is how you use it. And we sort of don't go through the different layers of what people really, what is it going to take for a person to think that, yeah, that's a change that I would like to take on myself. So for instance, in motivation, we could see from looking at those concerns earlier that there were clinicians that might have thought, if I was me as an individual, if I was to put nasal high flow therapy on my patient, if my organization doesn't support that, even if I think even if I've read the research and I know that it's good and that this might benefit this patient, I'm going to feel very uncomfortable about using that device if it's not supported by the greater health service organization. So we're just going to look at how we're going. So we're thinking back to those three aims in implementation science. So we have used evidence-based for wanted health outcomes. We know it's wanted because we did all that consultation. And so we did that literature review, and we've been able to provide a guideline using the experts, and that's been published. We then have gone through the process of implementing that strategy, and we were informed by the health service of the barriers and enablers, and we've been able to use our implementation science knowledge and work with the health service to identify strategies that would address those barriers and enablers. And now we're going through the evaluation phase. So we're using implementation science frameworks to evaluate those strategies. So like interviews, we're conducting medical file audits, and we're composing a document analysis. So from here, I'd like to say thanks. And I very much appreciate all of your time for listening to us today. But I just have one question for you at the end, and just to have a little think about. And for our in our research, we've used implementation science to try and create behaviour change for a context-specific problem. Is there any other potential scenarios that you can think that implementation science might be useful in your practice? So thank you.
Nice work. Thank you both. They were really engaging and excellent examples of research translation. Nice job, Ben. Oh, hello, Ben's baby. Well done, mate. They were great talks. Thank you very much. I'm going to open it up to the floor. I wonder if anybody has an answer to Sally's question at all. Merkel?
Thank you, Sally, and Ben, fantastic presentations. Personally, I was always keen looking at the hero change wheel, and what I used it for is back in time to improve hand hygiene practices in the large tertiary healthcare setting, and antimicrobial stewardship, in the private hospital chain practices, and also now I'm thinking about doing it in medication safety. So I think it's very, very applicable to all areas of our work. And I totally agree with your analysis and the wheel you show where the evidence is that motivation side is really that we need to work on, more to actually make it happen, for engagement. Thank you so much. And I learned lots with the resources here, and, just learning from your projects. Fantastic. Thank you very much.
Hygiene?
Hi, Sally. Thank you for the presentation. That was really inspiring, and I'm really touched that there is a nurse out there trying to implement research. I work in rural hospital, and my hospital side is going to implement high flow nasal therapy for the adult inpatients. So I'm not doing this as a project or research. As an educator, my role is to train up nurses to be able to use high flow therapy for the adult patients. And I have met with some resistance from the staff that about the anxiety surrounding using the high flow therapy for the patients. Because they're worried about retrieving patients and patient deterioration, etc. So what is your advice in this situation? So what I'm trying to do is I'm trying to get local clinical guideline updated, so our hospital can be included. And also I'm trying to train up staff based on evidence-based practice on high flow therapy. So this is my strategy so far. And is there any your recommendation in my context?
Yeah, thanks. I've got so much that I could talk to you about. This was in essence exactly what I started as. And I need to call out Alice Cairns here, because I started this out just the same as you, and I can see her in the audience. And I happened to just briefly mention to her that, could we actually just research this? And she went, yes. And then it like rolled on from there. So I can definitely see how you don't need to do it as a project. You can do it as just doing it as a clinician, which is exactly what we're wanting to take away from here. In regards to the education, I found that there was really, there were so many different facets of education that I needed to titrate to you, titrate for the health setting. Like, we noticed that there was definitely different, it's about knowing your audience. Say, like, if you're educating doctors versus nurses, there was a definite difference of preference of what people wanted. The frequency of education was different to what people had done in the tertiary setting before, because you're dealing with high turnover. And actually, there was a lot of education on, say, you think you might be looking at a guideline, developing a guideline. There was a lot of education about that. So the education was broken up into different components, and we sort of met with what we needed on the day. But I would definitely recommend you take my email down, and you and I can talk. And really, because that's really nasal high flow specific, and this whole audience might not want to talk about that. But and I definitely found that we needed to teach high flow for all age groups, is why it was my biggest takeaway. So even though the research was about kids in a remote site, people don't want to learn about high flow just for one age group. So we found that if you're going to use it for kids, then you need to use it for adults, and you might find the same.
Great, thank you. If is there another question from the floor? Because I have some, but I'm happy to defer. All right. Because of Haijian's question, and Sally, you touched on it, I had a question for both of you. Now, both of you are doing a higher research degree, right? My question really is, do you think that's necessary to do research translation? Do you have to do a research degree for that?
I'm happy to go first. No, you don't. So I guess that's where I used the example of the ERAS project, is that you can translate this research into practice without having to do a formalized research degree. However, it is fun to do the research, and it gives you that support. But yes, you can definitely do it on without doing a higher degree.
Yeah, I would say the same. And I've seen lots of really amazing projects that have happened in the absence of a research degree, and it's up to the person that's wanting to drive that research. Certainly you get lots of support in doing a PhD, or a master's, but there is work on top of that you have to accept that's just what comes, but you do get that certificate at the end. But I've seen lots of amazing projects where people are still getting a good amount of support, but they have just decided within themselves, look, I can't, like, if I did a PhD or a higher research degree on top of this, and the project wouldn't happen. So it's a nice dip your toe into research if you were to choose to do it without it. And it makes, there's still options of access to support without doing a PhD.
Fair enough. And I was wondering, Ben, Sally spoke about phoning friends, and she had a great slide about all the friends that she phoned and all the people that she had helping her. And you spoke about your TRIP training from Queensland Health. So what is your tip to people who are interested on how to start? What do they want to do? Where would they go?
I guess there's a few ways. You could reach out to Sally or myself and talk. I'm happy to talk about it. Very much endorse the process I went through with our trip. But it's also just reading about what's involved and getting that understanding. And probably the biggest thing, what I would then ask the person to reflect on is that research question. What do you have that you want to research? What's the evidence? And how applicable, or what are the barriers you think just off the top to really nut out whether it's able to be achievable, and in what context. As Sally touched on, it all comes down to those stakeholder engagement, getting the buy-in from a lot of people, and it's a team, it's a village, I would say, that gets one of these this translation occurring.
Yeah, when I talk about research, I talk about it being a team sport. You really don't do anything by yourself. You always phone friends, reach out. And that, Sally, brings me to you. Your project is a part of a larger study, and so I think for people online that might beg the question: well, how did you find out about it? How did you hear about that larger study, and how did you tap into it?
I just started looking at the literature on my topic and looked at authors and looked at who was doing what, and then fortunately happened to notice that there was a really, and the timing might have been right, and that there was a really prominent research group that I thought I might be able to ask them for help. And I hadn't been involved in the research community before, and I soon realized that it's a very supportive community and people don't care if you're a novice, and I certainly was, and they just are really happy to take your email. They're happy to call you and support you and direct you in the right way. And so I was actually quite lucky that they took me under their wing and made lots of things that gave me so much more advice. So I'm a person's personality type would be to sort of sit back in the back of the schoolroom and just sort of watch the rest of the lesson take by. But in this case, I didn't feel like that sort of I just soon learned that, ask your mates for help. It really does make things so much easier. You don't have to suffer and do it all by yourself. And in fact, it'd be virtually impossible to do it. So I was just lucky. And also, you can't do it unless you don't pick up the phone.
Fair enough. Are there any other questions from the audience? Are there questions in the chat at all, Bonnie?
No. Sorry, I've got one question. Do you want to go first, Bonnie?
No, you go first. You've got a question. Jump on in.
Sorry, it's Darren from Atherton jumping in. So it's interesting the point you made, Sally, about it's not just about the therapy. So it's not just about the nasal high flow therapy. You've also got to have the education foundation for your staff in the first place. So coming from a rural site, I'm really interested not only in the findings of Paris Remote, but further studies and trials in that area, because I think in the rural environment, I can totally empathise with you and Weepa that it's air retrieval. That's it. That's the only option that you have. We have a mixture of aeromedical and traditional road retrieval here, but because we're only situated hour and a half from Cairns, in some ways it makes it a little bit more difficult because we have the luxury of being closer to a tertiary centre when we can actually get a sick kid in the ambulance, worst case scenario, and get them to Cairns Hospital. But should we, we have good, strong clinical guidance there that shows us well, actually, if they meet the criteria, we can hold on to this sick kid. But a lot of the time, because we have that luxury of being so close, we just opt straight for the retrieval. So yeah, definitely interested more in some of the findings that are coming out of Paris Remote.
Yeah, I think that's really important that you mention that, because in essence, it might have been a little bit easier for me to sort of argue the point that because we rely on medical retrieval, then patients come in sick regardless, and we still have to look after them. So if you've got that time frame where you're waiting for a retrieval, it makes sense to increase your capacity and resilience. And in your case, you've got an hour and a half, but you've got to think about, like, as in, I guess I'm talking really about motivations. I'm going back to that wheel here where I'm saying the health service is motivated to have a responsibility to their patients, to have a really resilient and high capacity ability to provide care for their patients. Because at the end of the day, moving a patient from their home community is still a big deal, even if it's 90 minutes away. And we have that responsibility as clinicians to consider that. And I think we haven't really done that so much in the remote space because of the right reasons. We don't want people to get more unwell. We want to be responsible with the care we give. But now I feel like we're sort of moving more towards, we've been panicking for years in the remote space and maybe underestimating the service we can provide. And now that we've figured out that there might be an option here, maybe it's our responsibility to look at maximizing that before sort of moving everyone away. Because I've noticed during consultation that with community members that is like an entirely different theme that we didn't discuss today, but that is a huge, that is probably one of the biggest components that people describe, where they are so upset about when they're thinking about when their kids come in unwell, is that they don't want to be moved away. And I can imagine it would still be the same if I was if my children got retrieved even 90 minutes away, I would be hugely burdened by that. I would feel that.
And I think that's a nice segue back into, TAAHC is all about innovative health workforce models. What can we do differently? How can we translate research? And that's exactly where we want to go. What can we do to make the lives of our community members, the health of our community members, how can we make that better? I have one very quick last, no, I don't think I have one quick last question. One tip from each of you while I change my slides so that I can give a shameless plug for the next webinar. One tip from each of you, just one. Where on earth would someone start who's listening, who doesn't know where to start? Where would you point them? Sally, where?
I would just ask around. If you're a clinician, I would ask around the health service. I'd ask the universities that's nearby. I would just pick up the phone and start ringing, and people will show you the right way.
Cool. Ben?
Can't say much more. I just reinforce that. Reach out to someone who's doing it or has done it. We're always open to sharing because it's a wonderful process that makes positive changes for our patients.
Right. Thank you, Sally. Thank you, Ben. Thank you, audience members. See you next time.